Faculty of Medicine Universitas Airlangga can reach a great level in Asia and in the world.
Good afternoon, ladies and gentlemen. Welcome to the 115th Airlangga Webinar Conference Series in conjunction with Airlangga Professor Week. The topic of this webinar is Global Neurosurgery. My name is Arya, along with my senior, Dr. Ahmad Heriana, Specialist of Pediatrics, and my colleague, Dr. Sacha, Dr. Eko, Dr. Kenneth, Wina, Kevin, David, Dila, and Rahul. We are the organizing committee members of this afternoon webinar. This webinar is organized by the Faculty of Medicine, Universitas Airlangga, Surabaya. Before we proceed to the main event, we'll announce some of the rules regarding the certification and Q&A session of this webinar. Okay, thank you, Dr. Sacha. First, this is the rule about how to get the certificate. First, full participation during the webinar is required. The second, your attendance will be recorded by the Zoom application. Third, by the end of this webinar, participants are required to fill a questionnaire which the committee will send the link of in the chat box. And last, the certificate will be sent to your registered email address. Next. This is the rule for Q&A session. First, use the Q&A box on the middle of your Zoom panel to write down your question. And the last, question will be sorted and discussed after all lectures have been presented. Thank you for your participation, and we secretly hope you enjoy this webinar. We'll start this event with an opening remark from our host, Asra Al-Fawzi, MD, Specialist of Neurosurgery Consultant, PhD. Dr. Asra, the time and screen are yours.
Okay. Thank you, Dr. Arya and team. And of course, good afternoon, good morning, Professor Kroon, and also Professor Tarikan and Professor Binsu, and of course, our mentor, Professor Abdul Hafid Bajamal. So this time we are back again for our, conference series, and this time the title is about neurosurgery, global neurosurgery, and we are very glad and very happy to have very, expert and distinguished speaker from all around the world. And before we start this webinar, maybe we can hear our national anthem and continue with the hymn of Universitas Airlangga. Please, Arya, you can proceed.
Indonesia.
Okay, thank you very much, Dr. Arya and Dr. Chacha. And so we now move to the main session of this webinar. So I will let Professor Abdul Hafid Pajamal to lead the session as a moderator. Please, Professor Hafid, time is yours. Please unmute yourself, Professor Hafid. Okay.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everybody, my college, friends, Indonesian college, and also good morning to Professor Rob de Groen, my best friend from Holland, from Groningen. Thank you for joining us. This sunny day, we are happy to be able to meet in an honorable forum, Airlangga Webinar Conference Series. This time is for neurosurgery series. Now there will be three famous expert speaker of the world. First is Professor De Groen from Groningen, Netherlands. The second is Prof. Tariq Khan from Peshawar, Pakistan. And the third is Professor Bin Shu from Shanghai, China. The first speaker will be Professor Groen, will present about the quality registration of neurosurgical activity in Netherlands. That is very important for us. And secondly, Professor Tariq Khan also will speak about the neurotrauma care in low-income country and in low-income setting. And the third is Professor Bin Shu will talk about cerebrovascular revascularization, the indication and the techniques. Now, the three famous experts is a very important with their very important speech. It is, I am happy and we are very thankful to the speaker, to the expert for the availability to join us. we are Indonesian. Thank you for your coming. And I think I will try to give a short curriculum vitae of Professor de Groen. Professor de Groen finished his basic medical education in 1985 in University of Groningen, and he joined the military service until 1987. The training surgery, he got a famous expert. Professor Van Alphen is the famous expert of neurosurgeon in the world, and he was training by Van Alphen, neurosurgeon, also a famous neurologist in the world. Professor Osterhuis is also famous neurology, and also Professor De Ruyter, the general neurosurgeon, and he started his working as neurosurgeon in Groningen Medical Center, University Medical Center in Groningen in 2002 until now. So he's a senior expert of neurosurgeon in University Medical Center of Groningen, Netherlands. Please, we welcome you, Professor Groen, and you can start your presentation.
Good morning. I try to share the screen. I have activated it. I think it should be.
Yeah, please use wider screen, Professor.
Okay, yeah. I hope that it's.
Yeah.
Okay. Here it is.
Okay.
Sorry for the delay. Good morning here, but for you, good afternoon, everybody. Thank you very much, Professor Bajamal, dear Hafid, and also Asra for inviting me and for organizing this webinar. It's really an honor for me, having been several times in Indonesia, especially in Surabaya. We met each other already, and of course there is a big history, especially for Professor Bajamal, who has been trained in the Netherlands long times ago in Nijmegen. And well, we always feel the connections between you and Indonesian colleagues and the Netherlands. And so it's a big honor for me to have a talk here from Groningen for this audience. Well, as already was mentioned, I will have a presentation to share with you our first steps in improvement of quality of neurosurgical care in the Netherlands. We call it a quality registration program. And well, we will go through that in the next 20 minutes, and I hope that you will it will be of interest for you and helpful also. Well, not everybody is familiar with the Netherlands. It's also called Holland, and where is it here on the globe? It's a very small, tiny country on the shores of Europe. As you can see, we are a very small, tiny country. We have quite a few square kilometers of area, but a lot of inhabitants. At the moment, it are almost 18 million inhabitants, so it's quite crowded. I think we are the 15th crowded country in the world. Well, why is this of importance? You can see it's small, so the lines are short. There is a lot of communication connections, and that's also helpful for us to develop the quality registry that I will talk about. Well, what is one of the problems of the Netherlands, that is not only that it's small, but it's also low. To show here, the blue, dark blue is the area of the country that's below, it's on sea level, and the light blue is below sea level. So we are quite a wet country, and we have some measures taken. There are a lot of dikes here. There are a lot of windmills. That's the typical picture of the Netherlands, but nowadays we have a more sophisticated way to keep the water out, and that's by dams and by dikes and by very innovative constructions. In cases of high tides, we are able to close off the water lines and to keep the water of the sea outside. So that's how we manage already for many centuries. And what I'm now going to talk about with you is other types of management in our country regarding the neurosurgery. What's important to know that we have a socialized healthcare system, which means that actually everybody has access to healthcare, and everybody has a healthcare insurance for at least basic medical care. There are 126 hospitals in the Netherlands, but the neurosurgical care is covered by national laws. That means that not every hospital is allowed to start a neurosurgical department or facility. There are 18 hospitals over the country that are allowed to provide complex neurosurgical care, and that's divided among the university hospitals. We have 8 of them, and there are 8 large regional general hospitals that also are equipped with a completely equipped neurosurgical facility. Well, as you all know, healthcare is costly, and we have that problem here, of course, in the Netherlands, as everybody has, and we are facing a turning point because there's a continuous rising of costs. Here is an example of the situation in the Netherlands. We expect that around 2040, the healthcare costs will be doubled compared with the situation now, if we continue going the way we are going. So there are problems to be solved. There's a need to redefine the ultimate goal of care. Of course, it's important to work on prevention, to define what we need to do on curation, but of course also for chronic diseases, the disease management. And another issue which is getting more and more important with the aging of the population, the palliation. All of those parts of medical care are costly and need to be faced. We want, of course, the best outcomes for the lowest price. But for neurosurgical care, we have a big challenge because actually there's no systematically recorded neurosurgical outcome. There are some international systems like the Swedish system, but that's related on spinal procedures. There are the American and the UK databases and registers, but they are not related to complex neurosurgical condition. It's also very difficult to compare those systems, and that means that there is an increasing need for monitoring of outcomes, especially for high complex and low volume interventions, because they are very costly and they are significantly causing morbidity and mortality. And that's the field of care that especially we in neurosurgery are faced with. Well, all those things led to the design, to the idea to design a quality registration system in the Netherlands, especially for neurosurgery. It is a national outcome register, so every neurosurgeon is participating. What's very important, that is physician driven, which means that it's designed and maintained by the neurosurgical professionals from our national society, neurosurgical society. We think that's very important, because then we are able to give our own signature and to face the points that we think that are relevant. We have decided to start with 4 high complex disorders, not too many, not too few, and that is how we started in 2011. This initiative, of course, needs financing, and we found different parties who were wanting to help. One of them, of course, is the government, the National Healthcare Inspection, who's also keeping an eye on the process from the government side, and of course the healthcare insurance companies who are participating in financing, because it's also for them very important that they get the best care for the lowest prices. What kind of disorders did we decide to start with? We choose the aneurysmal subarachnoid hemorrhage. We choose the high-grade glioma, especially glioblastoma, pituitary tumors, and hydrocephalus for patients under the age of 2 years, which is also a complex category of neurosurgery. And the rationale for the choice was its relatively high incidence rate in the perspective of neurosurgery, of course. It requires all of them a complex multidisciplinary treatment. All the 4 disorders, they cause a significant mortality and morbidity, and it's a lifelong impact for the patient and for the society. This is a diagram that's showing the 4 disorders and some of the structure, what we are registering. For example, for the subarachnoid hemorrhage, of course, the number of patients, complications are scored, the time of bleeding, the duration of hospitalization, the type of treatment, different modalities of treatment, and of course, there's also the outcome after 6 months. For the high-grade gliomas, of course, the number of patients, the number of patients treated with a craniotomy. Of course, there are also cases that only got a biopsy. I'll come back to that later. Of course, we are interested in the complications. We want to know whether the patient has been operated in a reasonable time frame after the diagnosing by the neurologist. And of course, for the additional therapies, it's important, when did the radiotherapy start? How is the follow-up? How's the performance of the patient during follow-up? And how's the survival? For pituitary tumors, well, there are also the different modalities, and the same goes for hydrocephalus. You can look it up later. I want to go not further in detail of those 2. What's the purpose of the quality register? I already explained something about the financing part, but for us as a neurosurgeon, of course, it's also important to improve the neurosurgical care for our patients, but also the care given by the individual neurosurgeon. We want to keep the level high, and we want to stimulate each other. And the basic idea is about this register that it is an auto-regulatory system. The improvement of quality is being done by the participating stakeholders related to the outcomes that are presented about the different topics. Of course, as with all data sets, it's garbage in, garbage out. So the quality of the entry is, of course, very, very important. The entry of the data is being done by independent data typists. Of course, those data are anonymized. It's important that there is a verification of the data, and we do that by random sampling. There's also the cross-check with other registers. For example, we have a nationwide register for pathology, neuropathology. So all cases with a pathological diagnosis are in that database. So every glioblastoma is available and can be checked whether those are also registered in our quality registration from neurosurgery. Of course, anonymized data, but they can be coupled. So when there are missing cases related to the pathological database, then we know that there are some missing entrances, which is of course very important to correct. And what's also very helpful nowadays, we have in all our hospitals, we have an electronic patient file system. And although they are from different providers, those systems can be coupled and automated, and automatically anonymized files can be inserted in the quality database of our registry, which helps to minimize the dropouts. Well, how is the organization of the register? We have a register committee of our National Neurosurgical Society. Those are members of our society. There are 4 sub-registries related to all the 4 disorders I already explained to you. And every neurosurgical center has an expert, a delegate for one of the 4 disorders. So every center is covered with 4 experts for each disorder, and they are part of the expert group. There is an outcome data collection for each center, and it's possible to compare your own center historical figures with the present figures, but also possible to compare your own center's figures with the national average. And of course, it's also important to maintain the quality of the care cycle, which means that we take a very serious attention to the data processing. There needs to be done a correction for case mix when you are going to analyze, and that statistical analysis is being done by an independent external party, an expert, but not a neurosurgeon. Those data that are becoming available are discussed in per expert group. Those annual data are being presented yearly in our Dutch National Society, Neurosurgical Society. And what's important, that the intention of the quality registry is not to criticize any colleague or any praxis, but to share the findings and to let the responsible professionals compare their own data and to see how that will be of help, can be of help to improve their activity and their quality, and especially related to significant outliers. I will give an example of that later on. For that purpose, I have taken out a few of the data for the from the expert group of the high-grade glioma. Here you can see this, the geographical localization of the participating centers. This is Groningen. That's the place where I live, below sea level. And here I can show you the numbers of high-grade glioma patients. You can see here the years in the different colors, and these are the centers, and these are the numbers. And you can see here the number of high-grade glioma patients per year per center. Now you can see there are large centers, there are small centers. For example, this is Groningen, we are in the middle. This was in the startup stage, so there were a lot of missing data, but it's improving, and you can see here in the last years, but it's going to 2018 that I have the figures here, the data, and you can see that is quite a stable situation. Well, one of the things that we were interested in how is the relation between a craniotomy, so a real resection operation, and a biopsy in patients that are suspected to have a high-grade glioma. You can see here the national numbers, and you can see here the years. As I said in the beginning, there were missing data, problems with registration, and now it's almost optimal, getting to 100% of registration. And what you can see here, that there is some fluctuation. The yellow bars are the biopsies, and the blue bars are the resections. Well, it appears when we are looking in the time period between 2013 2018 and the different centers, that there is a variation in the percentage of biopsies. Again, here the missing in the white, the blue the resections, and the yellow the biopsies. You can see this is interesting, and it appeared that the average, the national average of biopsies is 32% here in our country. There are some other things that are of interest. For example, you see here the diagram of the age. It appears that when the patient is getting older, a higher percentage of cases are biopsied, and the number of craniotomies is decreasing. For gender, there's not a big difference. For the Kanowski performance score, you can see, well, that of course the Kanowski is important, but if even though the Kanowski can be performance score can be low, the craniotomy numbers can be relatively high. The ASA scores also have influence on the choice for craniotomy, resection, or biopsy. Well, with all those data that have been corrected for age, for gender, for Kanowski, and for the ASA score, we got the following numbers. The centers are anonymized alphabetically. Now they are numbered A to including M. You can see here the total number per center. This is the number of dropouts. That's very low. This is the observed numbers of biopsies. And here is the calculation, the expected numbers of biopsies. And you can see here the relative figures, the percentages of biopsies related to the total numbers. And that can be as low as 23%, but it can be also as high as 62%, which is of course of interest. Then the statistician is making a funnel plot of those figures. You can see here again the numbers of the centers here, anonymized. But when I am participating in the meeting, I know which number is our center, so I know for myself where we are. I don't have to show to everybody where I am standing, but I know well enough now how we are doing compared to the national average. So it appeared that, as I told already, 32%, that's the average, the national percentage of biopsies. And there are above that line, they biopsy more than expected. Well, this is clear. And when it's within this line, it's not significant. When it's outside the line, it's significant. And the same goes for the lower part. There are also centers with less than expected biopsies, which is of course also interesting and of importance to know and to see. How does this relate to other data registries? There is few literature on that. There are some examples I have showed you here in the diagram. Well, there is a diversity. In France, for example, in 2004, there was a paper where 43 hospitals were involved, and 44% of them, they performed a biopsy instead of a craniotomy. We are here, well, with a fairly number of 32%, but it can also be lower in the United States. In the SEER centers published in Cancer, they had a number of 12%. In the UK, all hospitals in that time frame, lots of cases, 11%. And we're in different group of hospitals in the USA. Already many years ago, it was 5%, and it seems quite low, relatively low number of cases also. But that can give you an idea how you should relate your own figures, your national figures, to the figures from other countries. Well, I come to the finalizing of my talk, which of course was brief, but hopefully illustrative. What can we conclude for the GBM registry in the Netherlands? We have a biopsy percentage around 30%, which seems reasonable. There's an indication, an association for biopsy indication related with age, higher ASA score, more likely to have a biopsy, because that seems to be better for the patient. Lower colonoscopy performance is associated with a low number of biopsies. The better the patient, the better chances that they will benefit from a craniotomy. What we also noticed that there's a variation regarding the indication for biopsy. There are two centers significantly outliers with more biopsies than expected, and there are also two centers that have less biopsies than expected, which is not well, it's a conclusion. It's just a conclusion. It's not saying anything about good care or bad care, but it's clear that related to the average number, they have to think about what might be the cause that they have those outlying figures. And maybe that can cause a change in attitude, a change in policy. And that's also the idea of the registry. So in summary, we have designed a national registry for complex neurosurgical cases at the moment, just for 4 disorders, but we are working on an increase of numbers. You can understand that this is very well, complex system to start and to design. and it needs lots of efforts and also financing to have this running. So it takes time, and it's important to become better and better and more efficient. It's embedded, that's very important, in our own neurosurgical society. It's not an other party that's telling us you need to do this and that and that and that, because that doesn't work. We are from the professional side aware what's relevant, what our patients need, and what we need to do our work properly and to improve. It's important also to work on an online up-to-date dashboard. Everybody has access, all participants have access to it. It provides insight in the performance of each participating hospital, and it's important to motivate outliers to critically review their own neurosurgical practice and to improve the process if needed. And we realize also we are just in a starting point to improve the quality of costs of care and to regulate the cost of the complex health care, which is a big problem that we are all facing in now and in the future. Well, this is what I wanted to share with you. Maybe there are some questions, and I would love to get back to that later. And I thank you very much all for your attention.
Okay, it's excellent, Professor Groen, excellent. Before I read a comment from the audience, I have some questions. It's beautiful. This is regarding quality of care and include the problem of how to control the cost. There is a question from me. Why you don't include the spine in your quality registration?
Well, that's a very good question, because the spinal procedures are a main part of our neurosurgical practice. That's definitely right. But one of the problems is that the spinal, it's such a high number that is, and it's being done not only by the neurosurgeon, but also by the orthopedic surgeons, which are large numbers of doctors. And that is very difficult now at this point to have a registry running on those cases, because it's, well, we call it, the spine is very diverse. You have the degenerative spine, you have the oncological spine, and there's no consensus on many things, how to treat, how to use instrumentation or not, with type of instrumentation, and it's very difficult to have a good insight in the costs of systems. And but of course we realize that it's very important to have that running too, and we are working on that. But it was not, because of the complexity, it was not a good idea to start with this, because it would be very frustrating. We wanted to start with disorders that we are, that we think we have a grasp on, that is in our domain. And so you are completely right. We need to go to the spine as well, and we definitely will.
Okay, excellent. The second question, Professor Groen, is about hydrocephalus. Now, I'm interested that the hydrocephalus still many incidents in Holland, because in my opinion that hydrocephalus more in lower and middle income country. Why you include the hydrocephalus in your four cases of interesting cases for the registration?
Well, we also a very good question. You are right that hydrocephalus is of course that's common neurosurgical practice, but the pediatric hydrocephalus has it decreased in number seriously in our country. But we have a lot of premature children that have intraventricular hemorrhage that need drainage. Some of them only temporary, but a relatively large number, they need definitive drainage. And those patients also are very complex because they're not of efficiency, dysfunctions, the policy how to drain, and we thought that this also would be an important topic. But to be honest, the registry of this type of hydrocephalus is very, very, very difficult because there is no uniform hydrocephalus problem. There are so many factors that are to be scored, and actually we made a miscalculation about how complex or how easy it would be to have this registry running. But I think it's typically related to our Dutch society here in the case mix in the Netherlands, and it's not to be copy pasted to, for example, the situation in Indonesia. And I can imagine that when you make this type of hydrocephalus registry, that would be completely different because the content of the problem is different.
Yeah. Thank you. The last question of mine is about this is important experience of your quality service of neurosurgery in your country. But how long is already done? Is it since 1930?
We started with the design in 2011, and we got it running in 2013. And we have it now, and of course that's important first to have some years to get sufficient cases, because you have to compare. And now we have on 3 of the 4 topics we have it very good running. We are really making progress in the statistics and in the comparison. And of course, the first thing you have to be sure is that you have all the cases. There cannot be dropouts. And what we also noticed, that not every center was very well motivated to participate, but it was not voluntary anymore. Now we have our quality registration is part of our registration as a certified center. So you are obliged to participate. Of course, there are people who are looking on the quality of data, and you cannot escape on that part anymore. So it's not voluntary, it's an obligation. Being part of our neurosurgical society, you also agree that you work in those lines. Otherwise, we cannot agree membership of those individuals who are not showing the responsibility towards the colleagues, but of course towards the patients and towards the society.
Yeah. Now the last question is, what was the pitfall? I mean, what is the problem you got from since a few years during quality service registration? What is your pitfall? What's the problem?
Why we started
the problem. It's important for us, your experience. What was the problem during registration?
Yeah,
to fulfill, to make everything's running.
Yeah, the design was important to have. Well, it was difficult to get to a proper design. What also was difficult because we discussed this in our annual meeting of our society. It's a topic: quality, improvement of care, cost regulation. How can we take care of that? And then the idea came, well, we have to see what we are doing. What are we doing individually? What are we doing as centers? We need to compare this. Although we are a small country, although the lines of communications are short, the distances from one to another hospital is short, we can look at each other's department, we can visit the OR, we have many contacts with the colleagues, not only professional, but also friendly. So this is the ideal situation to have, bring the ideas together and to work together. But still, it appeared that it's difficult. It's a lot of burden of work, administration, and we are busy with the patient care and other kind of things. But we realized we need to do this, and you need to motivate your colleagues, not only from other departments, but also in the own department. So we have the lines have to be short, but you have to be responsible towards each other. And that was a process. It was a difficult process, but it works. And now most of us are very enthusiastic about how we are doing with this system.
Thank you. Excellent. Professor Tarikan, maybe you have any question regarding the presentation?
No, really, thank you very much. Excellent talk and very interesting to see how you've developed the data and everything. We try a lot to get even neurotrauma registry, and it is so difficult because, as you said, people are not enthusiastic about putting their data in. And I think the only way to do it, as you pointed out now, that the society, the Neurosurgical Society here in our countries should put their foot down and ask them that they will not be part of the society unless they do that, I think. Thank you very much for sharing this very important thing.
Thank you very much.
Thank you, Professor Tarikan. I will read for you the question from the participants. First is from Perdiatama Sipak Budiono. Thank you for the presentation. I want to ask to Professor Groen, in current modern settings, how far the medical records should be taken in response to the risk of cybersecurity that faced by global healthcare?
Well, what's important when you have a registry like this, that all the data are anonymized, and that's the most important thing to start with, because well, here in the Netherlands they are very strict. Even it's almost unworkable to work with patient data. So they are very keen that when we insert some data of the patient in the registry, that is impossible for an outsider to get access to, but also to relate it to an individual. And but yeah, that's the starting thing you have to arrange. If you cannot secure that, you better stop starting, because it's for sure that you get incomplete data and you get numbers that are completely that are even dangerous to use for your praxis.
Professor Groen, how long have you done with the electric medical record?
Well,
medical record.
That's
about 10 years.
Yes, I think about 10 years. Yeah.
The question is whether there is a indication sometimes a cyber problem with the electronic medical record in your country.
I think that we had one situation that system was out of order, and that's disastrous. That's disastrous.
Oh.
Yeah, and well, that's always been my fear, but I realize that I am also getting a little bit old and of a generation that not grew up with electronic databases. But yeah, well, if there's no electricity, we don't have patient files anymore. We have no patient care. We have nothing. We shouldn't think about that. But that's really the weak point, of course. And what's also a problem, because here in the Netherlands, it's not allowed to have one system in all hospitals, the same system. That's not allowed, because let's say, well, that's the market. We are disturbing the economical market, because the parties that are providing electronic data sets, they need to have access to all. They will need to be allowed to sell their products everywhere, so to every hospital. The problem is that there's no connection between different sets. Also a problem.
Okay, thank you. The next question is, in your opinion, this is from Muhammad Fali Akbar. In your opinion, what is the ideal neurosurgeon per capita? What are Netherlands government policy that attempt to cover the neurosurgical cases?
Well, that's a very good question. Well, we have here at the moment, our number is, as I showed, we have 17 million inhabitants, and we have 150 active neurosurgeons, which means one neurosurgeon for 100,000 of inhabitants. But I think what's important, what kind of problems are you treating? How severe, how heavy is the number of trauma cases? What's the distance from the people living towards the hospital? What type of neurosurgical care are you providing? Is it basic care or is it complex care? Well, I think that's determining, and of course the geography. If you are in rural areas, the access, the time to get to the hospital will be significantly longer. Here in the Netherlands. Well, we there on every corner of the street. Well, there are many streets, and there are many cars, there are many ambulances. We have the helicopters taking care of patient delivery, etc. So the infrastructure is also very determining. But for example, Belgium, that's our neighbor country, they have one neurosurgeon per 50,000 inhabitants. We think that's too much. And we think they do a lot of surgery that we would not do. Well, that's typically Western problem, I think. Luxury surgery and finding indications. Of course, there are lots of indications, but well, then we are getting to the edges. And of course, there's the other side, that you have one neurosurgeon for 1 million. That's terrible. You will not. It's terrible for the neurosurgeon, and it's terrible for the patients. But we are happy with our number here in our infrastructure.
100,000, one for 100,000.
Yeah, that works.
Thank you very much. I think the time is running out now, so we have to move to the next session. We thank you very much. Your experience is very important for our nation, for our society, for the next few years. We will learn much from you, and we hope you will help us later. Thank you very much.
Sure. Thank you very much.
Excellent, beautiful.
Thank you.
Thank you very much. Now we move to the next speaker, Professor Tarikan. Professor Tarikan is a famous neurosurgeon and expert in neurotrauma. He is from Northwest General Hospital and Research Center in Peshawar, Pakistan. He is a well-known expert in neurotrauma, and he is also famous in the World Federation of Neurosurgical Society Committee. And we'll talk about the neurotrauma care in low income setting. or income resources. That's very important presentation. And I will present first the CV of Professor Tarikan. Professor Tarikan is the Dean of Northwest School of Medicine in Peshawar, Pakistan, and Chairman of Neurotrauma Committee of World Federation of Neurosurgical Society, and Chairman Alliance Healthcare of Pakistan, and also Convener for the Neurotrauma Committee of Pakistan, and President of Pakistan Society of Neurosurgeons. And also he is very active in several boards in DOST Foundation, Regional Institute for Policy Planning, Research and Training, the Abdul Hasim Khan Trust, and the Pakistan Human Development Fund, and the Aziz Jan School, Hayatabad, Peshawar, Pakistan. This is a very long experience and of Professor Tarikan, and we're happy to meet you today, Professor Tarikan. Thank you for your coming. Thank you for availability. We will learn much from you about the neurotrauma experience. Please give your talk.
Yeah, thank you very much. Thank you, Professor Hafiz Bajamal, for inviting me here, and also Fauzi as well. I'm just trying to see whether I can, yeah, can you see my screen?
Yes, we can see your screen.
Yes, beautiful.
Okay, so I'm going to be talking, as you said, on neurotrauma care in low resource settings. And sorry, no, it's not, for some reason, moving. Yeah, I just want to stop sharing and come back again, please. Can you see it? Yeah. Okay.
Yes.
Okay.
Good.
So I just want to first of all, look at the large numbers of TBI surgeries which are required in lower and middle income countries. These are old figures, but I'm sure they still stand. And these are the surgeries which are required, not the surgeries which are done in LMICs. And then 89% of surgeries for traumatic spine injury occur in lower and middle income countries. And we know that at least 22,000 neurosurgeons are required in the future. And you know that the World Federation has tried to look at to see how to figure out where the number of neurosurgeons are available in which place, and we found that they developed a workforce map, which you all must have seen as well. And this workforce map is available to everybody, and this is very interesting. As you can see that the lower and middle income countries' workforce is very low. So how to handle this large influx of patients? And we looked at it, and to try and figure out, we said we need to innovate in low resource settings, inform policy through research, and integrate into health systems with the help of the universal health coverage. So there has to be a holistic approach, and it should be prevention, pre-hospital care, emergency room care, ICU theater care, ward care, and of course, very important is the rehabilitation care has to be looked at. And there was a study done, if you remember, Professor Bajamal, you were part of that study, and the Asian Association Society of Neurosurgeons had done a small study and looked at what we were doing across the globe. And we looked at the helmet and seat belt use, and we found that only 7% of persons were wearing helmets and very few percentage were wearing seat belts. And then, of course, we want to get into the Guinness Book of Records to have as many people on a motorbike as possible. And we think that one helmet will protect everybody. So we started on prevention with a start that prevention of your and your family from head injuries. And we started these campaigns by poster competitions, by walks, by having getting students involved in schools and everywhere. And we then joined hands with Think First International Injury Prevention Foundation with the Neurotrauma Committee, and we had our first public awareness seminar on prevention of brain and spine injuries in Peshawar during the ICRAN, International Conference of Recent Advances in Neurotraumatology, back in 2019. And we're still running programs for school children everywhere. And then if you look at that, who was there the first responder was there to do that, and majority we found was that they were the laypersons. And was any nurse or paramedic or doctor in the ambulance when the patient was taken to the hospital? So of course not. There was nobody there, and of course most of the ambulances had nothing. We know that 50% of patients who die from TBI do so within 2 hours of injury, and 40% of pre-hospital deaths are preventable. And if you look at these studies, it shows that 59% of trauma deaths occurred in the field in high-income countries compared to 72% in middle income and 81% in low income environment. And the same study shown in Kenya, again, is the same, showing that very few people arrived into the hospital within 30 minutes of that, and only 72% within an hour. So obviously looking at that, for some reason, it's just a minute. It's stuck again. Give me a minute, please. So, and also looking at how long it took for surgery, and you can see that many more were more than 24 hours because of the long distances, the bad roads, and all these things. So obviously the outcomes were not as good as one would like it to be. The management is geared towards prevention of secondary injuries and rehabilitation, and secondary injuries like hypoxia, hypotension, edema, raised ICP, we know lead to increased mortality. So the longer the delay, greater is the mortality. For that, I think the ambulance service development was very important, and we were able to succeed in developing some form of ambulance service in our country, which have become the first responders now. And of course, guidelines are required in setting the minimal standards of care from the accident site, and a system of care which grows as trained personnel and resources become available. So they cannot be, obviously, it has to be an evolving system. And these are some guidelines which we made. But the guidelines are important to look at the profile of injury, the local data, the geography, the transport difficulties, and the resources. And then accordingly, we need to develop the guidelines. And if you look at this very nice recommendations of the Colombian Consensus Committee for the Management of Traumatic Brain Injury, which is called the bootstrap, beyond one option for treatment of traumatic brain injury. And this actually changed the perspective. In our commentary, we said that the paradigm shift from standard-driven protocols to resource-driven guidelines for neurotrauma management in low and middle income countries. And the scope of guidelines was to address treatment interventions that are specific to TBI, not intended to cover all topics relevant to the care of patients with severe TBI. And those recommendations are intended to provide the foundation on which protocols can be developed that are appropriate to different treatment plans. And the areas covered are pre-hospital care, emergency room care, surgical theater care, and ICU care. And these are now being tested in Colombia. So we know that in-hospital management is guided by GCS monitoring, CT scan, ICP monitoring, pupillary response, and the goal is supportive to prevent secondary damage. We all know the Brain Trauma Foundation guidelines, which are evidence-based. First line of therapy is head elevation, normothermia, sedation, volume resuscitation, CSF drainage, 3% saline or mannitol, and then second tier having decompressive craniectomy. And level 2 evidence we know says that biofrontal decompressive craniectomy has shown to reduce the stay in ICU, but not the outcome extended score at 6 months. And we need to have a large frontotemporal parietal decompressive craniectomy, at least 12 by 15 centimeter, to reduce mortality and improve neurological outcome. You all must have looked at the international consensus meeting on the role of decompressive craniotomies, and which was done in Cambridge in 2017. And I think it's worthwhile to study that because the pendulum keeps on moving from one end to the other regarding the management of that. And ICP monitoring, we know that there's level 2B evidence that it's important that it reduces 2-week post-injury mortality, and it should be monitored in all salvageable patients. And it's indicated in severe TBI with normal CT, but having 2 or more features on admission. But then you look at the high-end ICU in high-income countries, and of course, look at the LMIC critical care units, which are very poor and very poor monitoring. So the guidelines for LMICs, are not really available. No research literature to guide managing TBIs. Large part of literature comes from well-equipped large centers. No resource-based guidelines in LMIC to guide severe TBI management. So the best trip trial provided the only tested non-ICP management, and there was a lot of critique on that. And this trial found no evidence of outcome difference for monitored and non-monitored patients. And this trial compared ICP monitored patients with clinical examination, or called the ICE protocol. And then Professor Randy Chesser developed again this revised protocol for the treatment of traumatic brain injuries based on imaging and clinical examination for use when ICP monitoring is not employed. Of course, it's not a substitute for ICP monitoring, but and also not a substitute for evidence-based guidelines. But this is something which can be done. Now, in Peshawar, how do we do it? We either do a decompressive craniectomy on admission, or we do ICP monitoring through intraventricular catheter. If not, then we use the CRE-wise protocol. And the indications are for brain edema for decompressive craniectomy, effacement of basal cisterns, midline shift, GCS 9 to 12, or a drop of 2 degrees in that. And we try and do them at least in patients who are less than 70 years of age. And if there's a refractory ICP in patients we are monitoring ICP. So the CRE-wise protocol is based on the Marshall score, the interval CT scans, the clinical score, neuroworsening, the pupillary response, and then there's a 4-tiered management response. We all know about the Marshall grading. It depends on the cisterns, the midline shift, and the mass lesions. And intracranial hypertension suspected and treatment recommended in the presence of 1 major or 2 minor criteria. And the major are compressed cisterns, midline shift, non-evacuated mass lesion. And the minor criteria are GCS motor score of 4 or less, pupillary asymmetry, abnormal pupillary reactivity, and the CT classification of the Marshall score. So the neuroworsening is decrease in the motor GCS of 1 or more points, new loss of pupillary reactivity, interval development of pupil asymmetry of greater than 2 millimeter or bilateral mydriasis, and new focal deficit, and herniation syndrome. And the imaging schedule is initial and repeated after 12 hours if initial was less than 4 hours, then do it at 24 hours, then 48 hours, and then as required. And tier 2 is hyperventilation, hypertonic saline, or 3% saline by continuous infusion, increasing in sedation. And tier 3 is decompressive craniectomy, which we use, and controversial maybe hypothermia, and also people can use high-dose barbiturates. And of course, the tier 4 are the untested protocols with hyperventilation, imodapine, magnesium, hypothermia again. So escalating the tier therapy is when you see a neuro worsening here and no improvement or worsening on follow-up CT imaging and no acceptable response to that. So after 24 hours, we reduce the sedation, we see the clinical response, then we do a CT scan and then treat them accordingly. And this is a matrix to how to escalate the therapy to do that. But the important thing is the decision on trying to wean off the ventilator. And if you can see in the first 24 hours, it's more of red that you should not remove them off the ventilator. But then as over 48 and 72 hours, gradually, you see that you can wean off from the ventilator. I think this is very important to know how and when to do that according to the eye pupil response, motor response, and vocal response. Then in the same study, the Asian oscillation, we looked at where were these patients discharged to. And of course, majority were sent home to their families because neurorehabilitation or rehabilitation care is very poor and very expensive in lower and middle income countries. And what we looked at was that we were able to train the family members to try and look after the tracheostomy or the catheter care and the bed sores. And it has been fairly successful to be able to do that in our setup here. In 2019, with the help of Harvard School of Medicine, Key Park and the group, we developed the comprehensive policy recommendations for head and spine injury care in LMIC, and this was meant for policy makers. And the idea was that 80% of the world should have essential neurosurgical care by 2030, and 80% of the world is within 4 hours of a neurosurgical center by 2030. And this was a timeline we gave, and we hope that by 2022 in Bogota, we would have come to some head. But unfortunately, because of COVID and many other reasons, we were not there. But we are looking toward 2030, which is a period of universal health coverage for all countries supposed to be. And part of that, we developed the National Vision for Surgical Care 2025 as part of the universal health coverage. And in that, we piggybacked traumatic brain injuries and hydrocephalus in the National Vision. So hopefully that will be, it has been approved now, and hopefully it will be very helpful. So a new concept, as you know, global surgery and global neurosurgery, in addition to doing neurosurgery better, how to better deliver neurosurgical care to all who need it. And the Global Neurosurgery Committee was launched at the ICRAN 2019 by the WFNS, and Key Park is still chairing it, and I'm the coordinator lead for coordination with this committee. And the objectives are again the same: to engage all the stakeholders for building integrated surgical systems and to co-educate for investing in surgical care for all within the universal health coverage. Just explained earlier by Professor Green as well, the distances are much more here in these regions, and as you know, in Australia, they still practice by asking general surgeons to operate in faraway places. I think this has become easier because of teleradiology, Skype, and virtual surgical assistant, and guidelines also. So hopefully in future this would be helpful because of the reduced number of neurosurgeons. You know, in Pakistan, we are 1 in a million, one neurosurgeon for a million population, so which is very poor. To end it, I would like to invite you to the first WFNS International Global Neurosurgery Conference from 10 to 12 March 2023 in Peshawar, Pakistan. Thank you very much. Sorry for the glitches in the presentation.
Yeah, thank you, Professor Tariq. This is a very important presentation for us. because we have nearly the same situation as in Pakistan about management of the trauma. Now, one of the important thing is about the transportation and delay of the patient. So can you give some advice about the problem of delay?
Yes, so we worked with the government here in Pakistan to develop this ambulance service, pre-hospital care, and very interesting. One of our friends from Jaipur, India, he started training the shopkeepers on the roadside in basic life support and how to handle patients with trauma and that. So I think one needs to have an integrated pre-hospital care service. Obviously, the high-income countries have got helicopters and everything like that. Here, unfortunately, it is very difficult. But the government has to be involved with the stakeholders, and this is what we did here. And slowly, we're able to develop some form of pre-hospital care. And also, I think it's important, especially now with the mobile services available, that they can call up beforehand when they're transferring patients to do that. So I think gradually, and with these bootstrap protocols from Colombia, I think these are stratified protocols. You need to look at that. I think they are also going to be very helpful in that. Thank you.
Yeah. Now, this week we have a G20 meeting in Bali, the government of 20 countries. I don't see about the topic about neurotrauma they talk, but they were spine. They talk about spine, but no neurotrauma. What do you think about that? Maybe we can join in next year, maybe. What do you think?
Yes, definitely. I think it would be great because neurotrauma. The biggest thing is that it's young people. The spectrum of neurotrauma in LMICs compared to the high-income countries. In high-income countries, more and more going towards old age and more related to being on antiplatelets and falls, etc. Where the young, in our setup, is the young population on motorbikes, car crashes, falling from trees, buildings, kite flying, all that. So I think it is a disaster for the families who get a head injury, maybe the only breadwinner, etc. So it would be very nice to include that.
Okay. So maybe Professor Grun have a question for this neurotrauma problem, especially in low and middle income country.
Yes. Well, thank you very much, Professor Kaan, for your talk. It's very insightful for me also. The big difference you have to deal with the way the problems are coming to you, and it must be very frustrating to see this all happening and to be unable to get the numbers down, and in the cases that are coming to you, that they are coming as good as possible. So there's lots of things that have to be dealt with. And well, we of course also had here the situation of the head injury with the motorbikes and the scooters. And nowadays, even we have it with the e-bike. It is a newly a vehicle that's being used more and more also by elderly people. And also even here where the access of information is easier for a higher number of inhabitants, the wearing of helmets, the protective measures, that's of course prevention, that is so very, very important. And what do you think about the role of the government in this?
Yeah. So yeah, I see all the e-bikers, they don't wear helmets at all. Those special scooters or whatever they call them. So the government, and I'll tell you very interesting, you know, in Vietnam, in Hanoi, the government, the World Health Organization and the US aid got together. They made special helmets for us so that, you know, because it's very sticky there, warm there. And then they ordered that as of next week, nobody will be allowed to ride a bike without a helmet. And it made a huge change to the Hanoi population, to the mobility of head injuries. We have in Pakistan, or I'm sure in other countries, there are rules are there. So there's one rule, and it's sort of funny, but one rule is that the petrol will not be put in a motorbike if there's no helmet with the biker. So the petrol station has a helmet and they will give it to the motorbike, and they will just fill in petrol and take the helmet back. They will not wear the helmet. But they are slowly getting stricter and stricter. And the more people we ask, he said, no, I was the pillion passenger. I was not riding the bike. So I keep on telling that it's more dangerous for the back seater, the pillion passenger, because he somersaults across the main biker and do that. So we keep on doing, like in March, we are again doing a big prevention for the public awareness regarding head injury, neurotrauma care. I think the government can do much more. I think they can be more stricter. Sometimes they do, sometimes, you know, they just, so it's unfortunate.
Thank you.
Okay. Thank you very much, Professor Tarikan. I think we have to move to the next session. Thank you for your excellent presentation, and we learned much from you, and we hope in our national meeting in the next 2 weeks, I will introduce your idea and presentation also. Thank you very much, Professor Tarikan. And now we move to the next speaker, Professor Bin Su from China. Is Professor Bin Su available?
No, Professor. He provide a video of his lecture.
Okay.
Yeah.
Professor Bin Su is Professor of Neurosurgery, Department of Neurosurgery from Huashan Hospital, Fudan University, Shanghai, China. He's expert in neurovascular surgery, and he will talk about the cerebrovascular revascularization, the indication and techniques. Can we start the presentation of Professor Su?
Dear Professor Asra and Professor Pajama, it's my great honor to attend this Airlangga webinar. Today, my topic is cerebral revascularization, indications and techniques. My name is Bin Xu from Huashan Hospital, Fudan University. The indications of ECIC bypass, including the blood flow replacement. Normally, we use this kind of blood flow replacement in complex aneurysms and the score-based malignant tumors involving the vascular wall of the ICA, such as nasopharyngeal carcinoma, that we have to sacrifice the ICA and replace the blood flow of cerebral. The second type is the blood flow augmentation. Normally, we used in moya-moya vasculopathy and some chronic occlusion of ICA or MCA. So this is how much blood flow can be supplied to the brain after the combined bilateral revascularization of moya-moya. You can see the whole brain, was supplied by the ECA branches. The ICA was totally occluded after the treatment. And this is another case. You can see the whole hemisphere was supplied by the STA, even the contralateral side frontal lobe. This is another case for whole hemispheres plus fed by the ECA in ICA occlusion case. Personal experience in bypass, now I have over 10,000 bypass cases. For tailored bypass for malignant tumor and the giant complex aneurysms of ICA, at first we should estimate the natural collateral blood flow and then guarantee the enough blood flow replacement. Normally, we will do the 30 minutes balloon occlusion test. If the patient have no symptoms, we will decrease the blood pressure about 30%. If the patient still can tolerate very well, so this kind of patient don't need bypass. If the patient couldn't tolerate, we will use STA to MCA double bypass. If the patients couldn't tolerate the 30 minutes balloon occlusion test, this kind of patient all need bypass. So, like this case, the bilateral ICA was totally invaded by the tumor. So we should sacrifice the both side ICA before before surgery. We do the bilateral balloon occlusion test. You can see the ACAM was quite good. So I do ECA radioartery to M2 bypass. Combined double STA to M4 bypass. After this kind of one-side treatment, you can see the blood flow not only can feed the left side hemisphere, but also the right side. Then we both occluded the both side ICA. The blood flow was enough to replace. So I treated 31 cases for nasopharyngeal carcinoma, all successfully replaced the blood flow of ICA invaded by tumor. And the ENT doctors completely removed the tumor soon afterward. By now, the 3 years survival rate was 100%. The second type bypass treatment is for complex aneurysms, like this giant ICA proximal giant aneurysm. The neuroradiologists, they tried to use fluid diverter, but it's failed. So this is a preoperative balloon occlusion test. You can find a little collateral blood flow from ACAM and PCAM. So I use this strategy, STA to MCA double bypass combined with a progressive clip. This is designed by myself. And you can see at the first stage, we occluded the ICA around 70%. Then after 7 days, we totally occluded the ICA. You can see after 7 days, the ICA was totally occluded. The double bypass was all patent. And now the patient was very well. Type 2, ICA aneurysm, no collateral blood flow from ACAM and PCAM. So we should cover the whole hemisphere, MCA plus ACA territory. This is type 3, also ICA aneurysm, poor collateral A1 and the PCAM. So we should cover partially hemisphere, left side MCA territory. So this is all blood flow replacement for complex aneurysms. Because of the time limitation, I just take a glance. And this is a recurrent aneurysm embolized by coils. And this is all the surgical plan. We use ECA to radial artery to M3 bypass combined with progressive clipping. So this is a radial artery graft intraoperatively, then combined with progressive clipping of the right ICA. So for distal MCA giant aneurysms, we also should make sure to keep the enough blood flow replacement for M1 to M3 segment. We published this article in World Neurosurgery. This is a proximal part of MCA giant aneurysm. So M1 aneurysm and M2 aneurysm. We use a double STM-CA bypass. This is a distal bypass and combined with distal occlusion of the aneurysm. So you see just after 1 week, we couldn't see any aneurysm. This is a even distal M2 superior trunk giant aneurysm. So before, actually you can see the final result of the clipping was perfect, but to dealing with such a giant aneurysm, we need time. So before this procedure, I use frontal branch of STA to do a protective bypass with the M4 segment. So this gives us more time to treat it. So if the aneurysm have some enough length of both sides, we can cut the aneurysm directly, then do the proximal part to distal part to do the direct anastomosis. You can see this is a direct anastomosis after the resecting of the aneurysm. And this is a proximal clipping combined the distal bypass. All very successful. And this is a type 3, even distal M3 giant aneurysm. You can see I just use a distal clipping combined the distal STA to M3 bypass because this is a partially thrombosed aneurysm, so it's not easy for rupture. So this kind of patient we can use a distal clipping. Intraoperatively, MEP-SCP monitoring is routine in every complex MCA aneurysm. And after the treatment, we use ICG flow 800. It's very helpful in selection of the recipient artery. And the hybrid operating room is the best choice. So for the complication in this kind of treatment, in ICA giant aneurysm, no morbidity. But the MCA giant aneurysm, especially the M1, M2 segment, it's still very difficult because we still have 12% delayed infarction in small perforators. No mortality. The second type is blood flow augmentation. So this is normally used in Moyamoya disease or Moyamoya vasculopathy. So you can see the skin incision, bone flap, dural, and the targeted bypass. For ECA branches, we can use 3 branches. They are STA, or post-rectal artery, or occipital artery of scalp, and the anterior deep temporal artery, or posterior deep temporal artery of temporal muscle, and the middle meningeal artery of the dura. We normally use a combined approach for moya to allow maximum use of the 3 arteries. So in the intraoperatively, we should keep the integrity of STA and the deep temporal artery and the middle meningeal artery. The dural flap was also individualized design. And you can see this is a spontaneous stoma from middle meningeal artery to cortex. Intraoperatively, normally we can see the middle meningeal MMV combined at the side of the MMA. So we should use this kind of technique to protect the integrity of the middle meningeal artery. So after this kind of treatment, we formed this Chinese spring roll to keep the patency of the MMA, but at the same time, to stop the bleeding from MMV. Stoma located in ischemic area, and even 0.4 millimeter donor artery can be performed direct bypass. So after a successful bypass, we should find the red T sign, which means bidirectional fast blood flow. It also means a big difference of delta P. So this kind of bypass is sustainable. This is a SPECT after bypass. You can see the hemisphere's blood flow increased a lot. After the blood flow, this is a change of the blood volume in arteries. You can see the ICA under the basilar trunk, the blood flow was all decreased, and all the branches of ECA was all increased. For this kind of patient, they already exist ischemic condition, so the time is very important. So mean occlusion time of mine series is only 13.5 minutes. I use this kind of technique to harvest the STA. You can see from inner side of the scalp. It's very fast, only take minutes. And then close the incision from inner side of the scalp. So I always use the simplest bypass. You only use 1 or 2 or 3 curved microtemporal clips. Don't need to sacrifice any branches of recipient artery. This is a loop technique. You can see use 2 temporal clip and then cut an oval shape stoma and then do the stitch to the toe and here. Then one side, 4 loops can make 5 stitches. So totally 12 stitches, just like a clock. After the bypass, you can see the ICG. The blood flow was very patent. And in some cases, we can use keyhole approach. The bone flap was very small. You can see this is a very small keyhole approach, but the result is quite good. You can see this is a 4D DSA. The blood flow come to even to the monomer segment from ECA branches. From STA, you can see the blood flow come from STA to M2 segment, then redistribute the blood flow along the MCA network. This is a CT perfusion after bypass. You can see the hemispheres of left side, the blood flow increased a lot. So this is a long-term DSA result. You can see in most cases we can we can increase the blood flow for the hemisphere a lot. So the final type is a bypass for atherosclerotic cerebral ischemia. Normally for the ICA chronic occlusion and the MCA chronic occlusion. Like this is a ICA occlusion, MCA occlusion, and the Moyer-Moyer syndrome. And we have the new type after stent. You can see the stent caused MCA occlusion very fast. So this approach still same as Moyer-Moyer vasculopathy. But if the patient don't have the Moyer-Moyer syndrome, we only use a single or double bypass. You can see this is a Moyer-Moyer syndrome. The result is quite good. And use MRI, TASL. You can tell which part of the hemisphere the blood flow come from ECA, and some part, especially the thalamus and the basal ganglion, still come from the ICA. So this is my new design. The needle holder and the forceps and the scissors is very small, and you can see this is a real use in the anastomosing. So this single arm micro anastomose instruments was very useful in the deep located anastomose. So bypass technique is not a dying art. Ischemic brain can be revascularized, and the simplest bypass technique is easy to learn by residents. So this is a teaching course in Mayo Clinic and in India. And we are Huashan Hospital. We are the training center for WFNS and ACNS. If the young colleagues want to learn bypass technique, you can come to our hospital and we will teach you. Thank you.
Yes, thank you, Professor Binsu. Is Dr. Asraise, is there a question for Professor Binsu?
Yes, Professor. Professor Binsu is not with us because he, has to do some clinical work. Yeah. So no question for this. Yeah.
So we don't have any discussion about this, but maybe Dr. Professor Grun surgery. Do you have any comment, Professor Grun? Do you have many Moyer disease in your country?
No, it is a very interesting talk, and it's clear also from the presentation that that we here are seeing an expert in this type of surgery, revascularization surgery. Well, actually, here in the Netherlands, we have very few cases of moya moya, and I personally have no experience with revascularization techniques, and due to the fact that the number of cases is so low, we here have this type of treatment concentrated, and that is in Utrecht. Of course, the known department of former Professor Tulleken, who is very experienced in the design of the sutureless anastomosis techniques, with the excimer laser, the ELANA technique, and now they have the CELANA technique. He had, well, it's his life work on this design, and well, it's a pity that I cannot ask a question about the experience of our Chinese colleague with the sutureless techniques, and if he would ever consider to use those type of approach, because he also showed that even in very skilled hands, there is a limit to the occlusion time, and there are patients that, despite of the efforts to revascularize, get ischemic problems after the operation. And it might be that using a non-occlusive technique even can bring the results a little bit higher for those very complex and delicate patients. But I very much enjoyed, and I would like to compliment for this presentation.
Yes, thank you, Professor Groen. You mentioned about Professor Tulleken from Utrecht. I was in 1980 also enjoy his bypass surgery. I met him in Utrecht at the time. He's one of the founder of the pioneer of bypass surgery in Holland, I think. Yeah, is that right?
Yes, that's right. And he was also participating in that initial ECIC trial, which came to a very negative conclusion, which frustrated him very much, because he very much liked the idea, the technique, and as is shown today also, it is a good technique for the good indication, and that made him develop the non-occlusive technique. And yeah.
I think we come to the end of the session, and with the great speakers, we have received various information, and our thanks and appreciation goes to the speakers, a famous speaker, Professor De Groen, Professor Tarikan, Professor Su from China, and also thanks to the participant who joined this meeting, hopefully very useful meeting. And I return the chair to the committee. Please, Dr. Asra, thank you very much. See you again next time, Professor Groen, Professor Tarik also. Thank you.
Okay. Thank you, Professor Afid and Professor Groen and Professor Tarikan, and also Professor Binsu, that he could not make it this time. But I think it's a great presentation, good webinar. And thank you very much for all participants that joining us today, and also especially Professor Groen. I hope next year you will come here.
Yes, I hope to.
For your inauguration, and yes, I hope you can bring more educational, expert and experience to our young neurosurgeon that participate in this webinar today. So thank you, and okay, thank you, and goodbye for the next webinar. Okay, thank you. Good afternoon all. Terima kasih semua ya, Bang Hafid, terima kasih ya.
Professor Ohata. Konnichiwa, Ohata Sensei. O genki desu ka?
We are also the scientists. We are the practitioners.
Mangga Pak Kresna.
Tadi mungkin langsung pada pembelajaran dan
moments that you have interaction as powerful as possible and limit your
Tengah pandemi COVID-19 ini, kehadiran Unair semakin dibutuhkan.
Kita memahami bahwa COVID ini pandemi, penyakit ini menjadi permasalahan.
Thank you very much. Thank you very much for the question. It's very nice that you raised the issue of Zealand design.
For subarachnoid hemorrhage and due to family history. So,
by doing their cataract, I'm going to fix that. One thing a bit different from what Ike said, actually, I don't like to do femto.
After COVID-19 patient to physical fitness.
Okay, 3, 2.
Sebuah kebanggaan bagi bangsa Indonesia yang sudah diinisiasi oleh FK Unair.
Glukosamin itu kita mengimport 95%.
But for our research part, the conventional microarray.
Di sini telah hadir Dr. Fadil Ahsan, MSc PhD dari Jerman.
Acneiform eruption atau
acute hepatitis of unknown etiology in East Java and Indonesia. Hari ini saya coba mengupdate beberapa informasi terkait